Psychiatry here at the Health Science Center. He completed his medical school, psychiatric residency, and geriatric psychiatry fellowship training also at UT. Come on in. Dr. Schillerstrom is involved in multiple training, research, and clinical care activities at UT, including the establishment of a geriatric psychiatry clinic that specializes in cognitive impairments and depression in elders. He has multiple scientific publications and is currently involved in research protocols measuring the impact of medical illness on cognition, the association between depression and increased disability and mortality, as well as clinical trial research for Alzheimer's disease. So we're real pleased to have him today. Please welcome Dr. Schillerstrom.
Thank you. So I'm Jason Schillerstrom, one of the docs in the
He doesn't ever like for me to say all this.
I know. I always think that it's always only half the story. You know, it's not, here's Jason, his manuscripts have been rejected by multiple journals, his grants have been mocked in committee, and his wife thinks the grass is too high. Alright, so we're going to talk about pharmacological management of agitation in elders with dementia.
Would it help if I sit there? I'll be happy to advance them for you.
That's okay. Okay. Cool. So as a matter of disclosure, we do clinical trials in our department. The myriad of neurochem or amyloid modifiers. I don't think any of these clinical trials worked, so I don't think they'll be relevant to this discussion. So today, what we're going to learn is we're going to discuss the epidemiology, impact, and etiology of agitation in elders with dementia. We'll discuss treatments for agitation based on data from double-blind, randomized, placebo-controlled trials. There's one exception to that, but in general, this is limited to the gold standard in medicine. The other caveat there is I'm going to talk a little bit about antidepressants. I'm going to mention acetylcholinesterase inhibitors and mood stabilizers. What we're really going to talk about is antipsychotics, and then we'll talk about recommendations for treating agitation in elders with dementia. And so beginning with epidemiology, so the prevalence of dementia, 5 to 15% in persons over the age of 85. Behavioral and psychiatric symptoms, however, develop in about 60% of community-dwelling elders with dementia and about 80% of nursing home residents. Probably the most common, ambivalent about sitting and standing. So probably the most common referral I get from primary care doctors is for cases of agitated dementia. I get lots of patient self-referrals for depression and cognitive impairments, but coming from the internists, the family medicine docs, probably the most common referral I get is for dementia-related agitated behavior. And so I think it's important to know how agitation is measured in these studies, and probably the instrument that's used most often is the Neuropsychiatric Inventory, or the NPI. And so this is a caregiver questionnaire commonly used to measure behavioral disturbances in elders with dementia. Agitation and aggression are only one of the symptom subsets that it asks about. That's about all these others as well, and there's lots of others on here that can kind of play into agitation and aggression. So, for example, disinhibition and irritability. You know, usually these disinhibition and irritability are comorbid with agitation on the NPI. And just to give you an idea of how is it again that agitation is being measured? This is the standard agitation question on the NPI, and so what it does is it gives a prompt. It says, so you're asking the caregiver, does the patient have periods when they refuse to cooperate or won't let people help them? Are they hard to handle? And if the caregiver says yes, then if they say no, you move on to whatever the next question is, irritability or whatever. But if they say yes, then the assessors ask them all these other questions too. So do they get upset for those trying to care for them? Are they stubborn? Are they uncooperative? Are they cursing angrily? So the questions, you're suggesting to the caregiver all the possible examples of agitation in their loved one. And so once you got them thinking about all these symptoms of agitation, then the question is well, how often does this happen? Rarely, sometimes, often, very often. And then it's how severe is it? So mild, it can be managed with redirection or reassurance. Moderate, it's difficult to control. And then agitation, very disruptive. Medications often being required. For the MPI, the way that it's scored is you take this number here and you multiply it times that number there. So it can be anywhere from 0, if they say no, they never have that right there, anywhere from 0 to 12. So I think it's nice to kind of know the scale that you're working with. So the number that they're, again, the outcome measure is frequency times severity for these symptoms here. And there's other measures of agitation that you'll see in the trials that we talk about. But in general, this is probably the most commonly used instrument in these studies. And so we'll talk about the prevalence of agitation in elders with dementia. So this comes out of the Cache County study, big epidemiological study in Utah that looked at 408 elders with dementia. They gave the NPI at baseline and then about every 1.5 years thereafter. Reference for everything is on the bottom of these slides. And so they divided the sample then up into those who never got a follow-up. So they were trying to follow them up every 1.5 years, but maybe they only got baseline data. And then they are comparing them with those that got at least one follow-up. So you can see that those with no follow-up, they're a little bit older, a little less likely to have Alzheimer's disease. But what jumps out on this slide is that 25% of this sample is on psychotropic medication, right? That's a lot, right? 25% is on psychotropic medication. And you can see only maybe 5% are on acetylcholinesterase inhibitors. So again, this is the Cache County data. When you look at the prevalence of agitation in this sample, and this is based on the NPI, so these are all the NPI symptoms that they're assessing. You can see that agitation for those without follow-up is 20%. For those who had at least one follow-up, 10%. Maybe split the difference, say it's 15%. You can look at irritability. Irritability is quite a bit higher. Disinhibition is a little bit lower. But in general, in the Cache County epidemiological study at baseline, the prevalence of agitation, say it's about 15%. So it's not uncommon. If you just compare it to other studies, study done on 576 elders referred to dementia specialty clinics. Again, still looking at the NPI. Here you see it's about 35% in this sample. And so the first sample is an epidemiological study. Here they're looking at patients referred to the dementia specialty clinic. So that would be like the GEM memory clinic here at the VA. And so in that group, agitation's a problem in 35%. Irritability, you can see about 40%. Again, disinhibition, about 25%. And similar, here they stratify it by whether they have Alzheimer's disease, subcortical vascular dementia, or cortical vascular dementia. Again, they're using the NPI. They tailor it to just these symptoms. Agitation, again, you're seeing about 40%. And it's more common in those with cortical vascular dementia, a little bit less common in those with Alzheimer's disease relative to those with subcortical vascular dementia. And so the take-home message is that agitation is a common behavioral problem in elders with dementia. And it has clinical consequences, and so we know that it decreases the quality of life. It's associated with more rapid cognitive decline. It may be associated with decreased survival. Those studies are not as strong, but it's certainly associated with increased caregiver burden and early patient institutionalization. And so, looking at quality of life, one study looked at 101 elders with dementia and caregivers, and they assessed them for quality of life, behavioral and psychological symptoms using the NPI. Cognition was assessed with the Mini-Mental. They're looking at functional status, and they're also looking at caregiver mental health. And so we're looking again, they're wanting to know what predicts quality of life in elders with dementia. Do any of these things here predict quality of life in elders with dementia? And so, in the sample, you can see, looking at the NPI, you can see the correlation coefficient. So agitation, that's a moderate correlation, I guess, 0.34 on the low side, but nonetheless it is significant. depression correlated with caregiver-reported quality of life. Anxiety disinhibition somewhat. What's interesting, though, is that agitation correlated 0.34. It was significant. In this sample, quality of life did not correlate with many mental state exam, functional status, caregiver age. It did correlate with age of the demented elder and poor caregiver health. But at least in this sample, agitation was a stronger predictor of quality of life than cognition, as measured by the many mental state exam. Looking at caregivers' reasons for nursing home placement, a large survey, 2,200 caregivers from the National Longitudinal Caregiver Study, looking at 580 institutionalized. During this period of time, 580 of the 2,200 institutionalized their loved one over a 3-year period of observation. And so they asked the caregivers, those that had institutionalized their loved one, you know, why did you do it? Why did you place your loved one in a nursing home? And they said, you know, check all that apply. My health would not permit me to continue caregiving, so that's a caregiver health assessment. My loved one's behavior became too difficult to handle. Again, that's getting at agitation. My loved one needed more advanced or skilled care than I could provide. I need more assistance from others. And then I'll see this one in my clinic for patients who were just guilt-ridden. Well, others thought it was the right thing to do, right? And so, so they ask them these questions. Why did you place your loved one in a nursing home? And you can see that patient behavior, you know, about 45% stated that patient behavior was at least one reason for placing their loved one in a nursing home. And so, you know, potential causes of agitation in elders, the list is endless. These are the ones that I tend to see the most often. So pain can certainly cause agitation. Infection, and particularly urinary tract infections. Whenever I get consults, whenever I'm doing nursing home consults, and I get a new a request for an agitated patient, your UAs are always ordered just automatically. It's amazing how many UTIs come back. You know, typical psychiatrist, other medical causes, right? You know, the rest of the body. And then depression, delirium, and then of course there's other psychosocial reasons like just a poor caregiver-care receiver match. Again, I'm focusing on the pharmacotherapy management of agitation. The first step, of course, is to look at the underlying cause, and so we certainly wouldn't treat, you know, I don't know, a urinary tract infection with Risperidone, right? And so if treating the urinary tract infection can fix the agitation, fabulous. First step in management. And so in summary, the prevalence of agitation and other dementia-related behavioral disturbances is high, about 30%. It has serious clinical consequences in elders with dementia, so it gets them institutionalized, caregiver burnout, quality of life, increased rates of cognitive decline. And the cause of agitation in demented elders is multifactorial, and we always start with looking, whenever we get these consults, we always try and figure out what the cause is. Make sure it's nothing medical or untreated pain. Other psychosocial variables. And so now we're going to look at pharmacotherapeutic strategies for dementia. I'm going to start with SSRIs, briefly mention mood stabilizers and acetylcholinesterase inhibitors, but really focus on antipsychotics. That just seems to be what, whenever I give this, that seems to be where the questions are, is with antipsychotic medications. So starting with SSRIs, there have been 5 randomized, abbreviated RCT, but there's been 5 randomized, placebo-controlled, double-blind studies that have looked at using serotonergic antidepressants in elders with dementia-related agitation. And only one of these studies, these are the SSRIs that have been looked at in these 5 studies, only one of these studies reports that an SRI was effective for agitation, and the one that was effective is citalopram. And so just taking a look at that study, this is the one that came out as a positive result. It was 85 non-depressed elders with agitation randomized to Celexa, perfenazine, or placebo. Perfenazine is an antipsychotic. It's like it's a high potency typical. It'd be like Haldol or Prolixin. And so they're randomized them to either Celexa, a typical antipsychotic, or placebo. And this is typical of a lot of these studies, for 17 days. It's just sort of how long can we keep this group on this medication? So in this case, it was for 17 days. And that's about right for an inpatient unit. This was done in an inpatient setting. So 17 days is as good as they could do for this study. Their primary outcome measures the neurobehavioral rating scale, similar to the NPI. And so if you look at how the groups, it's about 80 years old across the different treatments. Mini-mental is in the 6 to 10 range. Most of them have Alzheimer's disease. Only about 10% have vascular. But again, what you're going to see in every one of these studies that I show you is mega high dropout rates. And so the dropout rate for citalopram was 52%, 55% for perfenazine, 57% for placebo. This is a problem in every study that I show you is dropout rates.
That just means they threw their hands up and went to some other treatment because
they either switched, exactly.
Or they had adverse events.
Or they had adverse events, or, right. It either wasn't working or they couldn't tolerate it. You're going to see that in every study I show you today. And so looking at the neurobehavioral rating scale factor, what you see is that citalopram, again, it's the only SSRI that's been shown to be helpful in randomized, double-blind, placebo-controlled studies for agitation. You can see that citalopram outperformed perfenazine and placebo in the agitation domain. What's also interesting is that it outperforms the antipsychotic for psychosis. and this isn't unusual. I'll show you another study with similar results.
So Jason, can you benchmark this for me? So that's like it's a 0.6 difference on the mean improvement on the scale. So is that a clinically meaningful difference?
This would be clinically, for this period of time in this group, this would be a clinically meaningful difference. When I get to the acetylcholinesterase inhibitors, there are statistically significant differences that are not clinically meaningful. Yeah. But in this case, this is clinically meaningful. What else? You can see perfenazine made them worse for motor retardation. Here, perfenazine, not statistically, but it does outperform the antidepressant for depression. So, what does all this mean? And so again, I showed you that citalopram, it does outperform perfenazine. This is the one non-placebo-controlled study that we'll talk about today. And again, just comparing citalopram with risperidone. So in that other study, you saw that citalopram was better than perfenazine, even for psychosis, right? And so this is a study, 104 elders with dementia-related behavioral disturbances. Again, it's an inpatient study, hospitalized on an inpatient psych unit. They were randomized to either Celexa or citalopram or risperidone for 12 weeks. They used the same scale, neurobehavioral rating scale. You can see the same age, essentially the same age, same mini-mental state exam as the previous study. Dropout rates are always huge in these studies, 52% for citalopram, 60% for risperidone. And for agitation scores, they're better at the end for those that were staying in the study. But they're equal. Citalopram was just as good as risperidone in this study. And then when you look at, this is their psychosis score, again, you see initially citalopram's a better antipsychotic than risperidone. Just that way. At the end, they're about the same.
So is a placebo on here? Where do you think the placebo on?
I would guess for agitation, I would guess it would be right about in here. I think it would have done better than placebo. I think it would have done better. And then here on I think both of these would have outperformed placebo, based on the results of other studies. But who knows? Who knows? Mood stabilizers. I'm just going to briefly talk about mood stabilizers. There have been 5 randomized controlled studies with mood stabilizers. The two that have been looked at are carbamazepine and valproate. Only one small study showed that these medications were effective for agitation, and it was carbamazepine that was effective. That's all I'm going to say about metastatic cancers. Acetylcholinesterase inhibitors. There's been 6 randomized controlled, double-blind, placebo-controlled studies looking at acetylcholinesterase inhibitors. The ones that have been looked at are ribostigmine, donepezil, and galantamine. 3 reported modest, very modest, but statistically significant behavioral benefits. The clinical significance on all of these was questionable. All right, so what we're really going to talk about those antipsychotics.
How many of these studies are industry-sponsored versus...
oh, they're like all industry sponsored.
Okay, so the sponsor may have an interest in the outcome.
Yeah, the only one that we'll get to the CATIE trial at the end, which is NIMH funded, but just assume that they're all industry sponsored. Yeah, they're all industry sponsored,
So
especially for the acetylcholinesterase inhibitor trial.
You're not going to go back to mood stabilizers at all?
No.
And aren't they pretty extensively used still for this?
Oh, all of this stuff is extensively used.
Out of
Sure.
desperation.
Yeah, it's all extensively used. It's just,
It's curious that there aren't more studies of mood stabilizers. So.
again, I'm really only looking at the randomized double-blind placebo-controlled studies. You know, there's lots of, you know, where they just put them on carbamazepine, and then they show that there's a mean difference between baseline and follow-up, that there's a statistical difference, but there's no placebo on it.
Right.
There's there's a gajillion studies like that. Yeah. Okay, so atypicals. Hands down, more studies have looked at atypical antipsychotics for the treatment of agitation in elders with dementia than any other psychotropic class. Like twice as many studies have looked at antipsychotics as the other classes of psychotropics. However, almost all of them, except for one, the CATIE study, all of them are looking at nursing home residents. 6 studies report improved agitation with an atypical. So 6 of the 11 showed a benefit. And all of these are the ones that have been looked at, and all of them have been shown to have a benefit. What you'll see is that Risperidone is consistently shown to have a benefit. Olanzapine is mostly shown to have a benefit. Aripiprazole, there's only been one study that had aripiprazole is Abilify. There's only been one study that shows it had a benefit, but there's only been one study, and as that one study, it worked. There's been multiple studies with quetiapine, and the only one that really shows that it might be helpful is the CATIE study. Almost all randomized, double-blind, randomized, placebo-controlled studies of quetiapine show that it's the least effective for dementia-related agitation, which I think is important to say because I can tell you that's the one I see is used the most. Whenever I go to Morningside Manor or whenever I have patients coming in for new evals, if they've been started on an antipsychotic already, chances are like 100% that the one that's been started is, I'm going to blind myself with this laser, is quetiapine. Yeah.
So I'm guilty of this.
Sure.
And I'm guilty of it because I believe that the side effect profile is better for quetiapine than Risperidone. I've had plenty of people that come on Risperidone who all of a sudden have Parkinson's symptoms.
Mm-hmm.
And I've yet to have that happen with Seroquel.
That is true. Side effects are less with quetiapine. Well, EPS, the risk of EPS, is less with quetiapine than with the other atypicals. But what I would argue is that as a geriatric psychiatrist, the truth is by the time they make it to me, I have a biased perspective, because by the time they make it to me, the least concern is EPS. You know, if they have a tremor or something like that, by the time they make it to me, they just want the agitation stopped. If they get a tremor, if they drool or whatever, families are willing to tolerate that. For stroke and increased mortality, there's no advantage to quetiapine relative to the other atypicals.
That's a really small increase across the board. I mean, that's why the black box warning is on there.
Yeah.
Plus that there's no real benefit. I mean, there's no proven benefit that these things really work in the long term.
Right. All of these are short-term studies.
Right. So,
and the risk for stroke and mortality is also this is also short-term
yeah,
data.
it's an absolute attributable risk of maybe 1 to 2% over what the risk would be otherwise.
That's true. When I consent patients, the number needed to harm is 55. So the absolute, if in placebo control, and we'll get to mortality at the end. I should save it till the end. I feel like I'm like wasting the punchline here, but but nonetheless, so like the mortality rate in the placebo-controlled studies is about 2.2%. In the treatment arms, it's about 4.5%. That gives you an absolute risk of about 2.2%. The number needed to harm then is 55. And so whenever I consent patients and families to atypical antipsychotics, I tell them, look, for every 55 elders that an atypical antipsychotic is prescribed for, 1 may die, and it's likely secondary to this drug. And so now it becomes existential. You know, for some families, 1 in 55, well, that's not that many. And then for others, 1 in 55, oh my God, that's a whole lot. And so, so anyways, you're right. The reason it is certainly associated with less EPS, but the risk is not any better for death and stroke. And a lot of times, by the time the patient makes it to me, they don't care about EPS, but they still do care about death and stroke. So. Okay, so risperidone. We'll look at it's a pool. I'll show you a pooled study. So more studies have shown positive results for risperidone for dementia-related agitation than any other atypical. So looking at the pooled data, I'll show you pooled data from 3 studies examining the effect of risperidone versus placebo for this. All of these studies were 12-week, multi-center, randomized, double-blind, placebo-controlled. And so the total sample, 722 of these. In these 3 studies, there were a total 722 on risperidone, 428 on placebo. You can see the age of the sample, many mental. Again, these are all nursing home patients. Only the dropout rate here actually is not as bad as the others. About 30%, I guess, weren't able to tolerate risperidone. So if you look at the agitation, so here we're looking at it, it's a different scale, agitation inventory frequency scale. What you see is over the course of time for agitation, 12 weeks, that the risperidone group does better than the placebo group for agitation. For side effects, you can see that about the same for falls, and I just picked selected adverse events. Here's the reference. Pull the paper, look at the 30 adverse events they looked at. These are the ones that I was most interested in when I put the presentation together. So for falls, it's the same. Somnolence, more with risperidone than with placebo. EPS, you know, about the same. And then stroke, but what you see again is a high relative risk, a small absolute risk, but again, it's, you know, the number needed to harm here is going to be about 50. So.
Yeah, these are short term, so these are like 12 to 24 week studies.
Right, that's right. 12 week, all less than 12 week. Yeah, 12 weeks or less. These are short term. Looking at olanzapine, this is one of the positive studies for olanzapine. 206 nursing home residents randomized to olanzapine or placebo. This is for 6 weeks. Primary outcome measures the NPI. And so here they're looking at different doses. So 5 milligrams versus 10 versus 15 for olanzapine. You can see essentially equal numbers across the groups for placebo. No real age differences, no real many mental differences. Dropout rates, over 6 weeks, about a quarter drops out, 24% placebo, less for 5 milligrams, less for 10 milligrams, more for 15 milligrams relative to placebo. MPI agitation aggression subscale results. So what you see is that on the MPI, their agitation subscale, the average drop was 2 points compared to 4 points for the 5 milligram dose, 3 points for the 10 milligram dose, or 4 points for the 10 and 3 for the 15. So olanzapine seems to be helpful, but there's not necessarily a dose response. Going up and up and up doesn't seem to make that big of a difference. Again, these are adverse events. What they reported, what I was interested in at the time, looking at falls, about the same for placebo versus 5 and 10 milligrams, but when you get to olanzapine, when you get to the higher doses, significantly higher. And so olanzapine is the most anticholinergic of the atypical antipsychotics, which could perhaps explain that, could explain the somnolence. Of course, Zyprexa is also the most sedating of the atypical antipsychotics, and so we would expect the somnolence rates to be much higher compared to placebo, and they are. And then looking at EPS and gait disturbances, 2% for placebo, 15 to 20% for the treatment group. And so in this study, olanzapine seems to help, but it doesn't seem to be dose related, and it certainly has side effects compared to placebo, serious side effects compared to placebo. This is the one study that's been done with Abilify or aripiprazole, 487 nursing home residents with Alzheimer's disease, randomized to either placebo or aripiprazole, looking at the NPI. They found a statistically significant difference. Maybe aripiprazole. One study. I'm going to skip through that and go to the CATIE study. So the CATIE study, the purpose, this is the NIMH funded study, and so for what they're looking at, they want to measure the effects of atypical antipsychotics on psychiatric and behavioral symptoms in patients with Alzheimer's disease and psychosis or agitation. So to get into the study, you had to have Alzheimer's disease, and you had to either be psychotic or agitated. And these are community dwellers. So they get 421 patients, and they randomly assign them to olanzapine, quetiapine, risperidone, and placebo. What's nice about this study, this is the only one that does head-to-head comparisons. And the ratio, it was a 2 to 2 to 2 to 3 ratio. And what's also nice about this study is that they're going for 36 weeks. So they have 6 follow-up appointments over the 36-week period. So they're trying to get beyond that standard 12-week trial. These are all their measures. Behavior is both the NPI and the BPRS. They're looking at depression, the clinician's impression of change. My favorite psychiatric measure. Hey, you look better. Huh? Okay. The 8S cog and the mini-mental for cognition. They're looking at ADLs, caregiver activity, quality of life scale. The average age was 78 years old, over half are women. 80% discontinued the medication before the end of the 36-week period. And so the way this study was designed, they divided it up into phases. And so for phase 1, it was all up to the clinician to decide if they wanted to switch or titrate. And so a patient would be started on an antipsychotic, and they would come back to a follow-up appointment. At the follow-up appointment, the clinician would say, maybe there's a side effect, so we're going to stop it, and they'll be switched to something else. Or maybe they say, well, it's not working, so we'll increase it, or whatever. And so what's nice about the design of the study is that it mimics real-life practice. And as it turns out, in real-life practice, 80% will discontinue the medication before the end of a 36-week period. If you look at the results here. So this is the last observation carried forward results. Let's see here. And so if you go to their agitation factor, what you see is that olanzapine outperformed placebo barely, statistically significantly, but barely. You see quetiapine did not. I don't think risperidone didn't either. This is the only negative risperidone study with last observation carried forward analysis that I know of for agitation. And you can, hopefully maybe your handout's better, but you can see all the different things that they're looking at between these three groups. So this is the last observation carried forward data.
So Jason, can you just go back to this? So this was also reported in the New England Journal in 2007.
Okay.
And there's another report from this study. So how is this paper from the American Journal of Psychiatry, do you know how it's different? I mean, what additional information is in this one than the primary report in the New England Journal?
I don't know.
Because
I'm not sure.
There's also just this gangbusters editorial that accompanies the New England Journal and how frustrating this all is, because essentially, I mean, yeah, you know, you're picking up these small differences here. This is essentially a mellotron.
Yeah, that's right.
Okay? So that these drugs really don't, when you put this into a clinical trial context, and placebo versus these three agents, there is no difference.
That is true.
For the dropout issues, there's the crossover issues, and I mean this is what we deal with all the time in taking care of these patients, and it's really distressing, especially when you also know that there's this small but measurable increased risk in doing harm by prescribing these agents. When the family and the patient are sitting in front of you, what the hell are you going to do?
Right. I agree.
But I just, you know, it is worthwhile for folks, if you haven't looked at the New England Journal article, the editorial that accompanies it, which also, are you going to talk about behavioral management at all?
I'm just focusing on pharmacy and the time we have.
Right, understand it. But so what it winds up boiling down to is working with families to make decisions about when, out of desperation, really out of desperation, because you have nothing else to offer, giving an antipsychotic that has some sedating qualities to manage a desperate situation. And really what the issue probably is training caregivers in specific circumstances to respond, building up their capacity to manage the behaviors in a non-pharmacological way.
Right. Yeah, that's right.
I'll tell you why I feel so passionate about
it. So looking at the, so this is the data for those that were able to stick it out. And so purple is Zyprexa, Seroquel is green, Risperidone is blue, placebo is orange. For those that were able to stick it out, so this isn't the last observation carried forward data, this is just those who were able to...
Survivors.
The survivors, right, for 12 weeks. You can see that those who were able to stick it out did do better than the placebo group. And they all do about the same. Okay. So, essentially, and then there were no differences between groups for activities of daily living, cognition, quality of life, or caregiver activity. So even if you did improve agitation, none of this other stuff improved. Death. Let's see here. So, I need to work on this slide. Alright, so this is aripiprazole. Let's see here. Olanzapine, quetiapine, risperidone. Yeah, and risperidone. And so these are the odds ratios for mortality. And then the meta-analysis, this is the 2005 JAMA article. The overall odds ratio is 1.54, and it does become statistically significant. So what I want you to see is that they're essentially all the same. None is really, when it comes to killing old people with antipsychotics, none will do a better or worse job than the others, in general. I think that's fair.
What about the older drugs like Haldol?
And then when they've compared them with typicals, there's no difference there either. Although, I'm only aware of studies with haloperidol, comparisons with haloperidol.
So this is a great slide because it also points out the difference. If you look at the overall odds ratio, you can say there's a 54% increased risk of dying on these drugs. Well, actually, absolute risk is only about 1 to 2%.
2.2%. In this study, it was 2.2%. The absolute risk was. So, again, this is the conversation. When I start atypicals, this is the conversation I'm having, much more than increased tremor. Okay. All right. So, in summary, what is known? So, what we know is that there's no FDA-indicated drug for dementia-related agitation. We know that unlabeled or off-label use of antipsychotics is very common practice. We know that there are more randomized controlled studies for antipsychotics, and within antipsychotics we know that there are more for risperidone than for other classes of medication. Randomized controlled studies show a modest effect. However, the placebo rate is high, and dropout rates are always high. Incidence of mortality and stroke is high. And we know that atypicals are less likely to cause EPS than typicals. However, no other differences in efficacy or safety have been demonstrated. So that's what we know about antipsychotics in elders with dementia. What we don't know is individual medication differences. The CATIE study is starting to get at that. But we still don't really know it because like everybody dropped out of the study, right? So we don't really know if risperidone is truly better than quetiapine because there's only been one study, the CATIE study, that compared the two with the placebo arm. The risk of CVAs, we don't know about death and stroke beyond the 8 to 12 week studies. We don't know risk factors or protective factors for antipsychotic-associated CVAs and death. And then we don't really know the efficacy and safety of treatment alternatives, including psychosocial interventions. The literature is full of psychosocial interventions, and in general they show effects, but they're not that much better than the antipsychotics. So we don't really know that either. So these are the official recommendations of the American College of Neuropsychopharmacology. So of course first is determine and treat the etiology of agitation, which is what we said right at the beginning, right? We don't treat urinary tract infections with Zyprexa. Okay. Good routine clinical care may be helpful as evidenced by the high placebo response rates. So just seeing the patients often, establishing the relationships with families like Dr. Lichtenstein is describing, just good routine clinical care seems to be helpful. Clinicians should make decisions based on the patient's and family's values regarding quality of life goals. If you're going to use antipsychotics, you have to involve families. I think you're just opening yourself up to a world of hurt if you don't consult families before starting these medications. Identify target symptoms and establish a time frame.
In a nursing home, the nursing home will not start the agent until the family member has signed and given permission.
Yeah, and I can tell you, I don't start the agent until I've called the family member and talked with them about it myself.
Well, in an urgent situation maybe, but you have to document in your note that it's an urgent situation and why you're choosing that drug.
Identify target symptoms and establish a time frame. If you put someone on risperidone and it's clearly not helping, you know, what I'll sometimes see folks do is say, well, maybe if we augment the risperidone with citalopram, if it's not working within a reasonable time frame for agitation, this should be a reasonable time frame. It's probably about 2 weeks. If you don't see a clear benefit within that period of time, reconsider your treatment plan. Remember that not all psychotic symptoms or agitation needs pharmacotherapy. Again, going back to what Dr. Lichtenstein was saying, use the lowest dose of medication for the shortest period of time necessary Of course, minimize side effects. Monitor effectiveness regularly. Commonly used research instruments may not be feasible in clinical practice. Sometimes people ask me if they should implement the NPI in their routine practice. I don't suggest that. What works is talking with families. And again, if there's one key message that I hope you get from this talk, is that if you're considering antipsychotic therapy, you gotta talk with families. And if the families, if they don't see improvement, then my God, stop the medication. And then we monitor safety every 3 to 6 months, monitor for EPS, blood pressure, body weight, glucose, and lipids. Okay, so those are the official recs. Educate patients and caregivers about the risks and benefits of medication. Tell them what to do if a side effect occurs. Don't hesitate to consider switching. And then, what we never have time for is coordinating care with each other, right? So try that. Again, going back to not to hesitate, consider switching. The truth is, when patients come to my geriatric psychiatry clinic with dementia-related agitation, we're almost always able to help them, is the truth. It's very rare that that we don't achieve success. It's very rare, and the reason, it may take 6 months or however long, but eventually we get there. And I think it's just because we keep trying. The other side of that coin, though, is maybe just with the passage of time, the agitated behaviors go away. But in general, I can tell you, because we keep trying, because we don't hesitate to switch, because we don't just start augmenting with the stuff, we're almost always able to help patients and their families. So, all right, more references. If there's 2 articles I highly encourage everybody here to get and read, it would be these 2. So, Pharmacological Treatments of Neuropsychiatric Symptoms, the JAMA article, and then just a general summary statement of antipsychotic drugs in elders with dementia. These are the 2 I would get. If there's only 2 articles you look at out of all these references you have, make it be these 2. Okay. Cool. All right. We have time for questions.
You didn't address trazodone or Buspar.
Yeah, there's been no randomized double-blind placebo-controlled studies. Doesn't mean they don't work, but it doesn't mean they do. So, in general, I don't use trazodone or Buspar for agitation. I don't. I might use them for. The truth is, I only use Buspar for SSRI-induced bruxism, and trazodone I'll use for sleep, but I don't use them for agitation.
You use a mixture of citalopram, risperidone, and eventually carbamazepine.
I try not to. Yeah. What may happen is that I may get a consult on an agitated patient, and they may already be on citalopram, and there may be good evidence that other things have been tried, and so then I'll start risperidone and leave the citalopram on board. But then I'm always, depending on the outcome, I'm always trying to get it down to one medication. And even once I get it down to one medication, I'm reassessing later to see if they still need it. I try. What you're describing happens is common practice, but we try really hard to not go down that road of adding and mixing, and we try not to.
Now these, most patients I see are demented, but they also are delirious.
Mm-hmm.
And they have reason to be delirious.
Okay.
Does this data change for somebody that's got a post-cabbage delirium and is also demented?
It would be. That's a whole different game.
That's a whole different game.
Delirium's a whole different game. And so we know delirium is an independent risk factor for mortality. And we know that antipsychotics, particularly the stronger dopamine-binding antipsychotics, really risperidone and olanzapine, treat it. What we don't know is, does treating the delirium with these antipsychotics, does it improve survival? We don't know.
I guess if the agitation resolves, let's say, in a period of 2 weeks, the idea is to discontinue the medication, probably restart if the patient get agitated again.
Right.
Because there is no experience until.
Right. That's right. Yeah. I usually like them to be stable before I take them off of it. And there's no good data to support this. This is just my clinical practice. I like them to be stable for 1 to 2 months. You know, that gives the family a chance to breathe before I taper and try discontinuing the drug. So I like 1 to 2 months. But again, that's just my clinical practice.
So these drugs, from my perspective, should be used as drugs of last resort.
Right.
And the clinical criteria that I have for using them is if the agitation is posing a danger to the person themselves or to others. So, you know, if a person is getting out of the house and wandering around in a neighborhood unsupervised, or has, you know, problems and they're clearly impaired, that's not a safe behavior for that person. If they're hitting other residents or other people, I mean, there may be other reasons in the environment why they're agitated and why that behavior is triggered. You've got to identify those and get rid of those. But if you can't identify those, then again, out of desperation, you wind up using these drugs. There are medical legal implications because of the black box warning. So if you do choose them, you have to say why you are choosing them in your note. The fact that you've talked and counseled with people about this, and in spite of the known risk, you are doing this because you believe that the benefit is always going to be better to control this dangerous behavior. My mother is, people are going to get tired of me talking about my mother. She has Alzheimer's disease and she's agitated, and she's on CATIE-AD. And she was started on this by a geropsychiatrist over a year ago. And we tried tapering it back here in San Antonio. And in the personal care residence where she lives, there are some small children. And she believes these small children are hers. And as the Seroquel dose was coming down, she was getting interested in maybe disciplining these children. You know, grabbing and saying, you know, don't do that. You know, why aren't you listening to me? And fortunately, we've worked with the caregivers, and she's still on the drug, but they're now using this as a PRN. And when she gets agitated, they have learned ways to manage her and redirect her. Sometimes she feels like she's got an appointment and she has to go meet somebody. So they say, okay, we'll walk with you. They'll take her out, go for a walk, and bring her back to the house. And then she's tired and goes to sleep, and they were able to take care of it without using the drug. It's personally distressing to me that she's on this. But I don't know what else to do under the circumstances. She's on a lower dose than she was before.
Right.
But there you have it.
Yeah. Yeah, it's tough, and you know, I'm not talking about behavioral interventions. Maybe I should, but you know, well, you know, in nursing homes, I think nursing homes are a nice example where if the person that I'm being called to help, if the family has hired, you know how they'll hire like a private caregiver to be there with them at the nursing home, I'm almost always able to use behavioral interventions in that setting. Where I can't is when that person's not there and it's up to just the normal overstressed, overworked staff.
It does come down to these issues, the relationship and caregiver, getting to know the person, trying out different things, what works, what doesn't, and some sort of familiarity, so that they're able to perhaps tolerate the behavior a little bit more. And the same thing's true for families, learning how to, learning skills and techniques to be able to deal with the behaviors more effectively. I think you know, when you're giving a pill, it's a standardized dose of a known entity.
Right.
Behavioral intervention is so dependent on the persons who are delivering that intervention that training people to deliver a behavioral intervention in a standardized way and testing it has got a lot more complications, and it's much tougher to do.
Yeah.
But I think there is really something to be said for, just empirically, for well-trained caregivers and longitudinal relationships.
Jeff, did you have?
Yeah, Jason, what significance, if any, do you make of the observation that the only negative study on risperidone is a non-industry sponsored study, and the positive ones were from the industry sponsored study?
Yeah, I don't know. I don't know what to make of that. I mean, the truth is, in some ways, I really like the CATIE study because it does mimic. It was designed to mimic clinical practice, but I don't know that it really shed more light on. I don't know. I don't know what to make of it.
I would take one CATIE study over any of the others.
Yeah.
Because it's the best scientific test to date of the effectiveness of these agents.
Yeah. So, I don't know what to say. Apart from CATIE, they're all industry sponsored.
How the patient can drop out of the study if they are dementia? I guess the family would have to give the consent for the trial.
Right. Yeah, so family can pull them out. And then in a lot of these studies, the CATIE being a nice example, the clinician pulls them out. They say, you know what, things aren't going well, we're going to remove you from this study.
Yeah, I mean, that's an obligation of the investigators. If there's an adverse event, you have to stop the study. And if the subject, these people are profoundly demented, so I don't know what they can say themselves.
The 80% failure rate in CATIE wasn't for adverse effects. It was part of the study design that they switched drugs for lack of efficacy. So in other words, they were forced by the study design to change drugs if they didn't think the first one was working, and that was counted as a treatment. So they weren't pulling people out for side effects, and which were not very common.
Usually there were a fair number of adverse events.
Well, there probably were, but it wasn't that they were 80%.
I mean, those were in the New England Journal.
So there is a subset of responders, and those that are able to take the medication. There is a subset of responders to that.
It's true.
Let me get your question, then we'll go. Yeah. Did you have a question?
Is there any indication for short-acting benzos? I know we try to stay away from that.
In all of these studies, the caveat is always, and we removed all of their psychotropic medications except they were allowed to take Ativan, PRN. So that's how all of these are done. And so is there, I don't have any data to share with you on that, but I can tell you that I think even in the CATIE study, they always allow for Ativan is the one that's just always, even in the placebo, they always allow for, Ativan's the one that they allow for. So.
Do we know if there is a stroke area of the brain that is more frequent for the stroke related with this medication?
Yeah, I don't know. I don't know that.
They don't even know really it's stroke.
It's just general cardiovascular disease.
They don't really know. It's just sort of, somebody said it was a stroke. I think there's another issue in these trials. Since most of them were done before Lewy body disease was widely thought about. And Lewy body disease is thought to have higher agitation rates, and they also have the psychotic symptoms, one of their case-defining symptoms, visual hallucinations. So I imagine one of these nursing home studies were done actually with Lewy body patients who were selectively vulnerable to the side effects of neuroleptics. And the high prevalence of, if you look at the side effects that are distinguished from placebo, it's Lewy body symptoms like falls, orthostasis, hypersomnolence. Those are all Lewy body type procedures. So it may be that, that these drugs look bad in those studies because they target the very people who shouldn't be on neuroleptics.
Thanks for coming.
Thank you.
Yeah.
Bye.